heart failure is an increasing problem for the aging population, especially among the women. Based on the recent USA statistics, the prevalence of heart failure among the older women more than 75 years is 10.9 than in men of the same age group, that is 9.8. So, the etiology of heart failure in women influences both the selection and outcome of the treatment in regard to the morbidity and mortality. The major differences which comes in my mind about the heart failure etiology, one of them is, of course, the structural anatomical changes in between the men and women. Women typically have smaller heart and blood vessels than the men do. Because of this, heart diseases can present and progress differently in men and women both. These risk factors were highlighted by Dr. Amber Ashraf, but when we come to the age and the comorbidities, it is more common in men. And in women, BMI, atrial fibrillation, and lifestyle factors are more common in women, which can, as well as hormonal influences, heart failure phenotype, and renal failure sometimes. These are the common factors which can give rise to the women more heart failure. Coming back towards the Framingham heart study, if we look into the back into last century, I was a part of that study, rather heart inter-heart study. It shows that independent in age, below the age group of 40 years, it was independent heart failure incidence, which was 1 in 5 for those who were less than the 40 years old. In the same cohort, at the age of 40, lifetime risk of heart failure without myocardial infarction was 1 in 9 in men and 1 in 6 for women. At that time it was low. Over the past 20 years, with research work in this, mainly it was found that white cohort women, incidence of heart failure was rising faster in women than men. It comes to 9% with 6% in men. So that is the significant rise of heart failure in women than men. Apart from the age group, most common reasons are hormonal dysfunction, especially estrogen. Estrogen affects collagen synthesis, and this degradation inhibits the renin-angiotensin system, and loss of its protective mechanism may render the heart of post-menopausal women more vulnerable. Other gender differences in underlying mechanism identified, which were calcium handling, nitrous oxide system, and natriuretic peptides. As Dr. Amber Ashraf said, polycystic ovary syndrome and menopause are typical diseases which are closely related to the hormonal changes. In several epidemiological studies were conducted which highlighted the difference in the incidence of heart failure and its consequences. It was found that in 1 year survival rate in especially heart failure study, men were more sufferers than the women, 43% incidence than the women, which was 36%. Left ventricular dysfunction, which was found in SOLVE study registry. In that study, 22% women were having more left ventricular dysfunction associated with the mortality rate than the men. In hypertensive patients, it was found that there was threefold increase in women leading to the heart failure than the men, in whom twofold presence, 39% heart failure was present. Myocardial infarction, of course, the incidence was increased in the men, 34 with 13% in women. Diabetes mellitus, although it was later on found that the incidence of diabetes creating heart failure was almost same, but those studies told that in women diabetes was the main reason for the mostly reason for the heart failure. Coming back towards the hypertension, as one of our speakers told that women are suffering more from the hypertension and related heart failure. That is the reason for the ejection fraction preserved heart failure in women, which is more common. Only one prospective cardiovascular health study with 66 months follow-up on a large population with an average age of 72 years old reported heart failure incidence, which was more with in 21.2% for female and 33.6% for male. That was the only study in which hypertension associated with the heart failure was more in males than the female. But another study, which is more recent, shows that 10 millimeters of the reduction in systolic blood pressure can reduce the incidence of congestive heart failure by 50% in women at the high risk of hypertension, which is associated with the heart failure. So that is the maximum reduction with 10 millimeters of mercury reduction, which can bring the risk of mortality and heart failure down. So the role of early detection is important. Among these studies, it was found that there was significantly higher association between women, gender and hypertension. We can see that in female there is a higher risk for the heart failure. It was supported by two other studies, Martinez and Hellerman's study. Both reported that a difference in heart failure and preserved LV dysfunction was 60 with 29% between women and men. So preserved heart failure was more common in the women than men due to hypertension. Another study suggested the correlation of the LV function and non-ischemic etiologies in both gender. If we are talking about the ischemic heart disease leading to the heart failure, definitely men are more sufferer, but in women, non-ischemic etiologies were more common in the women. So significant correlation was found in women gender and preserved LV function was more common in women. Male gender has a significantly higher correlation with coronary artery disease and ischemic etiology as discussed earlier. Regarding diabetes with heart failure, the gender differences, the results were almost similar between male and women. These were the study outcomes of a recently conducted study. If we are talking about the cardiac troponin difference, marked variation in the cardiac troponin concentration have been detected between the women and men, with higher values commonly found in men because of the increased coronary artery disease. Coming back towards the anti-pro-BNP in both sexes, The association between the NT-proBNP and heart failure was stronger in men than women. This was the first study which disclosed that. But before that, most studies which found that at the baseline, NT-proBNP level were lower in males than in women. So these are the additional risk factors. Even in health, in a normal man and woman, they tend to exhibit higher level of the natriuretic peptides and galactin 3 and lower level of the cardiac troponin and cardiac stress marker, soluble ST2. These can provide a reliable explanation of these differences, which highlight the body composition, fat distribution, and postmenopausal status. So that is the reason that these are more in women and can lead to the, because of the fat distribution and body composition, they may have later on more risk factors like hypertension, diabetes, and the patient may have heart failure. If we are talking about the drugs used in the heart failure, there was no significant difference in the usage of angiotensin converting enzymes, the ACE inhibitors, angiotensin receptor blockers, anti-aldosterone drugs, diuretic, beta blockers, nitrates, and statins in both groups. But the difference was in between men and women for taking aspirin and clopidogrel, which was more in men. In this regard, a study was conducted in the Dow University of Health and Sciences in 2017, and which highlighted that the use of aspirin was comparatively more in male than the women. 334 with 218 in women, and clopi was less used in female than the men. The conclusion of that study was there was a greater bias in the use of anti-failure pharmacotherapy due to the socio-cultural reasons and economical conditions of the women in comparison to men. Underpinning current sex disparities in heart failure, there is paucity of the women recruited to the heart failure clinical trials. 25% of the cohorts, and thus treatment guidelines are predominantly based on male-derived data. This is the whole conclusion or summary of what we, our lady cardiologist told us during this session. Increased age at the diagnosis, decreased hospitalization rate, increased hospital stay during the heart failure, increased ejection fraction preserved heart failure, decreased quality of life, and better prognosis for all-cause death, CV death and heart failure hospitalization. So these were overall the summary which we talked about during this session. Thank you so much.